Alright, my objective this week was the treatment of pheochromocytoma, and you'll see up here that I put PPGL, which stands for Pheochromocytoma paraganglioma, and that is how it's actually named in the clinical practice guidelines of the Endocrine Society written in 2014. And it's because of a lot of the overlap, the significant overlap between a pheochromocytoma and a paraganglioma. In my opinion, this overlap is like the overlap between diarrhea and bulk stool. They both stink and they're often brown, but they are clinically two different things.
Alright, I'll just briefly remind you that you have an autonomic nervous system. The autonomic nervous system composes of the sympathetic and the parasympathetic. So the sympathetic is called the thoracolumbar, and the parasympathetic is called the craniosacral nervous system. So you remember that the parasympathetic nervous system starts with a preganglionic axon. So this is the preganglionic axon. It synapses onto a postganglionic nerve, and it releases acetylcholine onto a nicotinic receptor. The postganglionic nerve will release acetylcholine onto a muscarinic receptor. Then the sympathetic nervous system will synapse, the preganglionic axon will synapse in ganglions around the perivertebral ganglia and release ACH. So we're all releasing ACH in the preganglionic axon. We're releasing that onto nicotinic receptors. It's always going to be the same no matter what nervous system you're looking at. And then the postganglionic axon, it depends on where you're at. So if you're looking at sweat glands, it's going to look exactly like the parasympathetic nervous system. So sweat glands of the sympathetic nervous system are innervated and use the same neurotransmitters as the parasympathetic system. However, if you're looking at almost the rest of the sympathetic nervous system, you're going to release norepinephrine, and you'll also notice that the fibers branch much more in the sympathetic nervous system than in the parasympathetic nervous system, and they're going to stimulate alpha or beta receptors. The sympathetic nervous system also innervates the adrenal medulla, stimulating it with acetylcholine on nicotinic receptors, where it releases epinephrine, norepinephrine, and dopamine. Dopamine, you'll remember, can act on alpha and beta receptors as well as dopamine receptors, and which receptor it acts on primarily will depend on what the concentration is. For the most part, when you think of the adrenal medulla, you want to think of epinephrine. And when you think of nerve terminals, you want to think of norepinephrine. The last thing I'll point out about this is you'll notice that I drew the sympathetic nervous system preganglionic fibers short and the postganglionic fibers are longer, whereas the sympathetic nervous system, it's the opposite. That has one important implication, and that is this: because there's branching in these postganglionic fibers, that indicates that the sympathetic nervous system, large groups of it, can be activated at the same time, and typically that's how the sympathetic nervous system is adapted. The sympathetic nervous system can be totally turned on and totally shut off, all basically at the same time without much sequelae. On the other hand, with the parasympathetic nervous system, there's a whole bunch of side effects with medications because we're trying to turn off one thing in one organ system, and it's not programmed to allow systemic shutdown or activation of the parasympathetic nervous system. So big picture, we have the autonomic nervous system, we have a craniosacral parasympathetic nervous system, long preganglionic fibers, they synapse, they release acetylcholine onto nicotinic receptors. They have short postganglionic fibers that project onto muscarinic receptors. Then we have the thoracolumbar distribution of the sympathetic nervous system. These short preganglionic fibers synapse onto the perivertebral ganglia. The nicotinic receptors receive acetylcholine and activated. The short preganglionic fibers also synapse on the adrenal medulla. The longer postganglionic fibers branch extensively and release norepinephrine onto alpha and beta adrenergic receptors. There are two things when you want to know what the sympathetic nervous system is going to do. The only important things to know or to talk about are the receptor type and the tissue. So the receptor type I'm talking about, is it an alpha-1 receptor, is it an alpha-2 receptor, is it a beta-1, a beta-2, and recently characterized the beta-3 receptor. A lot of people like to remember beta receptors. They'll say beta 2 and beta 1. We'll remember that there are 2 lungs and 1 heart. So you remember that beta 2 bronchodilates, whereas beta 1 causes inotropic and chronotropic effects on the heart. I personally like to think of them like this. I have alpha 1 and beta 1, and I'll let that 1 represent an up arrow. So 1 stands for up, and that is because these are the things that control hypertension. When you activate alpha, you get vasoconstriction, and you will increase the blood pressure. When you activate beta, you're going to do a couple of things. First, you're going to stimulate the heart, which is going to give it an inotropic and chronotropic activity to increase the blood pressure. The second thing is it innervates the juxtaglomerular cells of the kidney, and these will cause the release of renin. Renin will activate the renin-angiotensin-aldosterone system, which will cause the retaining of water, increasing the total volume, which further increases pressure. Then you have your alpha 2 and your beta 2. Importantly, these are both going to contradict what's going on over here. So it's basically inhibiting alpha 1 and beta 1 hypertension. It's not inhibiting the alpha 1 and the beta 1 activity, but it is preventing the hypertension. The alpha 2 does this passively, and this occurs through feedback inhibition. So alpha 2, so norepinephrine can be released from a nerve terminal, a postganglionic nerve terminal, into a tissue, and some of that norepinephrine will go back and stimulate alpha 2 receptors on that nerve to inhibit further release. So that's peripheral feedback inhibition. There's also central feedback inhibition. So central alpha 2 receptors will prevent the preganglionic fibers from releasing the acetylcholine onto nicotinic receptors. So I say alpha 2 is passive because you don't get any prevention of hypertension unless the alpha 2 is activated. It can only be activated whenever the other mechanisms that cause hypertension are activated. Then beta 2 activation will cause vasodilation. Importantly, not only do alpha 2 and beta 2 resist the hypertension caused by alpha 1 and beta 1, but they have an important mechanism. I like to put diabetes, alpha 2 and beta 2 can increase blood glucose. And what happens is alpha 2 will cause insulin to be released, beta 2 will cause gluconeogenesis and glycogenolysis. In the same vein, beta 2 receptors will stimulate lipolysis on adipocytes. This barely scratches the surface with the sympathetic nervous system. I think 3 other really important things to point out and how these are used pharmaceutically with sympathetic agonist and antagonist are in the bladder, the colon, and the eye. So we take a real quick look here at the bladder. We can see that we have alpha stimulation, innervation near the sphincter, and we have beta and muscarinic receptors at the detrusor. So what we get is alpha activation causes tightening of the sphincter, so we're going to prevent urine from being released. Beta activation causes relaxation of the detrusor. So what happens if you have sympathetic activation? You relax the detrusor, you tighten the sphincter, so you retain urine. On the other hand, if you activate the muscarinic receptors, it's going to cause detrusor contraction. It's not extremely high yield to know this, but it probably will be shortly in the future, is that beta 3 receptors have been characterized in the bladder, and there is pharmaceutical development surrounding these things for different kinds of urinary incontinence. It is, however, important to know that the prostate, which I have drawn here in blue, also has some smooth muscle in it, and that smooth muscle has alpha 1 innervation, and so you can use alpha agonist antagonist to modulate the contraction of those smooth muscles as well. Now at the colon we see basically the same thing. We see beta causing relaxation, muscarinic activation causing contraction or peristalsis rather, and then at the sphincters we see alpha 1 innervation where we're getting tightening, and so basically sympathetic innervation will cause the colon to retain and to constipate. And so that's your paradigm. Alpha 1 causes sphincter contraction, beta 2 causes relaxation, and so you're going to retain things. This is a little bit different in the eye. So let me go ahead and draw a cornea here, draw the rest of the eye around here, and then back here we have a lens, and surrounding the lens we have an iris. This iris is chock full of muscle. So let's go ahead and draw our muscle like we normally do with this red salmon color. So we have these muscle fibers that are running in this orientation linearly, and then we have other fibers that are running in a concentric pattern around a circle. So we have basically two orientations of muscle fiber. It is important to know that these are stimulated by alpha 1, these are stimulated by muscarinic, and I believe it's M3. So in this case, parasympathetic is going to cause a contraction or a miosis, a contraction of the pupil, whereas sympathetic activation is going to cause mydriasis. Now I always remember it mydriasis, wide eye, and miosis with a pinpoint pupil. Furthermore, behind the lens, actually attached to the lens, you have some cilia attached to a ciliary body. And the ciliary body is innervated by beta 2 receptors, and these are causing the production of the humor. So with beta activation, you're getting this fluid production, which is going up, around, and down through the canal of Schlemm. With glaucoma, you're getting, where you're not able to drain that fluid for whatever reason, and so you can actually stop the production of that fluid with a beta 2 antagonist, and then you can also give a muscarinic agonist that will pull everything this way and open up the canal of Schlemm. Now you'll remember that if somebody has taken a sympathomimetic, let's say cocaine, for example, someone has taken a sympathomimetic, you cannot give them a beta blocker alone. This is called unopposed alpha stimulation, and this is the basis for how you treat pheochromocytoma. So unopposed alpha stimulation, remember that the alpha 1 and the beta 1 will increase the blood pressure, the alpha 2 and the beta 2 will cause a relative decrease in blood pressure. Now it would seem like if I knocked this out and this out, I have balanced myself out, but that's not the case. The reason for this has to do with Starling's law. First of all, alpha stimulation is always going to increase the blood pressure. It's always going to cause vasocontraction and cause increased blood pressure. On the other hand, if I knock out this one, I don't have a vasodilation. So knocking this out is always going to cause an increase in blood pressure because I don't get the dilation. Now, what would it do if I blocked the beta 1 in this situation? If I did that, I decrease inotropy and chronotropy, right? So if I look at my preload and I look at the cardiac output or the stroke volume, there's a Starling curve that shows basically a linear relationship up to a certain point that as I increase the preload, the more is going to be put out. Now whenever you give a beta blocker, that is how it decreases the blood pressure, is it adjusts this Starling curve. And so now I have a curve that comes down here. So a given preload, I'm going to have less output. But you'll remember now, I'm talking about the preload, and so what determines the preload? Well, there are a couple of things. Venous return is one important thing, and afterload is another important thing. Ultimately, I can superimpose on here a venous return curve, and then when I have vasoconstriction, I'm going to shift that venous return curve. And so I went from a total cardiac output right here to a total cardiac output right here. And you'll see that that did not decrease it very much. And this is the effect that I get by blocking my beta 2 receptors. So blocking the beta 2 receptor is going to cause a shift in the venous return, which is going to stop any useful effect of the beta 1 blockade, and it's also going to now no longer have any opposition against the alpha receptors, and so your blood pressure could theoretically skyrocket. Okay, so going over everything in the notes, we have talked about autonomic control of the eye, we've talked about autonomic control of the bladder and of the colon, and now we have also covered unopposed alpha activation, and I've re-explained it here. In essence, beta-2 activation balances alpha activation. So if I get rid of beta-2 activation, I no longer have any balancing force on the alpha activation, which is going to cause an increase in blood pressure. Blocking the beta-1 activation does not have any real effect on that hypertension, and that is because the venous return curves are altered. Okay, so that gets us into the alpha blockers. Phenoxybenzamine is an irreversible, non-selective alpha blocker, so it'll block alpha-1 and alpha-2. Basically what this means is it takes about a day for your body to replace an alpha receptor. So if you block that irreversibly, then you have completely shut it off for the entire day. The goal of the alpha blockade in pheochromocytoma is that you get the drug levels up high enough that every alpha receptor is basically shut down for the duration of a surgery. There's another alpha blocker, phentolamine. It can possibly be used in place of phenoxybenzamine. And then there are the selective alpha-1. These are selective alpha-1 blockers, and they end in azocin, so prazosin, for example. And the way I remember these is the A stands for alpha, the Z means nothing, alpha-1 selective inhibitor. And I decided to go ahead and write that out for you. Okay, so we all knew that we needed to give phenoxybenzamine for about 7 days. After the alpha blockade had taken full effect, start giving beta blockers propranolol. We all knew that, and we knew that it needed to continue the treatment for up to 10 to 14 days before the surgery. And so we have all of that covered for the most part. But what I need to point out is, okay, first of all, we got it right. We did exactly what the Endocrine Society clinical practice guidelines say to do. The Endocrine Society in 2014 issued their clinical practice guidelines on how to treat pheochromocytoma. Now, due to 3 different things, these clinical practice guidelines might not have to be your one and only. For example, there are side effects, there are costs, and there is time. So it can take up to 14 days before you are able to get a surgery with this. What can happen in 14 days? Well, a lot can happen. I mean, potentially even statistically small, but potentially you could even get a metastases in that time frame. Now, I explained to you that alpha-1 causes sphincter contraction, and so it makes sense that you would get a retrograde ejaculation. This is one of you see those wild things that just pop out at you. That's what this is. And then the more common things: orthostasis, nasal dripping, and stuffiness. And I'm not saying that the retrograde ejaculation is not common. I don't know how common it is. It just popped out at me. The prices of some of these medications have also been in flux, so phenoxybenzamine, and then we're going to talk about Metyrosine in a minute as well. Those prices have been changing quite drastically recently. So your other options are you can use nifedipine, which is a dihydropyridine calcium channel blocker, and you'll remember that this can block calcium channels and cause vasodilation. It is not a And so the non-dihydropyridines will also have a cardiac impact, but the recommendations don't say to use those, verapamil and diltiazem. It says to use the nifedipine dihydropyridine calcium channel blocker. So whenever you're using this as monotherapy, you can still have cardiac increased contractility, inotropy, chronotropy, which actually may be helpful if you have a cardiomyopathy like we did in our case. So the catecholamines have caused the dilated cardiomyopathy, and so you can keep your cardiac output up in situations where you wouldn't be able to if you were using a beta blocker. This is not without significant side effects, but the morbidity and mortality overall has been about the same as the standard treatment. Another option is, instead of using phenoxybenzamine, you can use the alpha-1 selective drugs, and in those cases you can use them in two ways. You can use them as your primary pharmaceutical, whereas you would not use phenoxybenzamine, or you can use them with phenoxybenzamine while you're loading up, and when you have those paroxysms of hypertension during that loading phase, that 7 to 10 day phase, you would add an alpha-1 selective to deal with those paroxysms. Metyrosine is the third option, and the reason we have this option is because it's a lot faster. The Mayo Clinic has been using this, and they can get to surgery within about 5 days.
So let's talk really quick about how metyrosine works. To make the catecholamines, what you're actually going to do is you're going to use convert tyrosine into DOPA. That's with tyrosine hydroxylase using tetrahydrobiopterate, converting it into dihydrobiopterate. Then from DOPA, you go to dopamine. That requires DOPA decarboxylase. And from dopamine, you go to norepinephrine. This is a vitamin C dependent process, and it uses the enzyme dopamine beta hydroxylase. Now, vitamin C is important because the only other place you're going to really see this in biochemistry is in collagen production. Now, from norepinephrine, you're going to produce epinephrine, and that requires PNMT. That stands for phenylethylamine N-methyltransferase. Sometimes it's called norepinephrine N-methyltransferase. The thing that's important about PNMT is that it is a cortisol-dependent enzyme. That means whenever cortisol is present, the expression of this enzyme gets upregulated. So that is why it's so important for the adrenal medulla to be in closer proximity to the adrenal cortex. Biochemically important is that this process requires S-adenosylmethionine. It takes a methyl group from S-adenosylmethionine and converts that into homocysteine, making epinephrine. Okay, so what does all this have to do with metyrosine? Metyrosine actually blocks DOPA decarboxylase. So if you administer metyrosine in the right concentration, you can actually prevent almost all epinephrine and norepinephrine from being produced in the adrenal medulla especially, but you have to be careful. This will also prevent norepinephrine from being produced everywhere in the body. So it's not without consequences. But again, the major benefit is that you can reduce the wait time down to 5 days. Now, we've said that there are 3 options for treating a pheochromocytoma preoperatively, and the major option recommended by the Endocrine Society is to administer phenoxybenzamine for 7 days, and then for the next 3 to 7 days, administer phenoxybenzamine with propranolol. Now we have to talk about the non-pharmaceutical preoperative treatment. During catecholamine excess, you get increased blood pressure through 3 mechanisms. The first and foremost is your alpha-1 is going to cause vasoconstriction, and that's going to increase blood pressure. The second is you're going to get your beta-1 that's going to give you inotropy and chronotropy on your cardiac myocytes. The third one is also a beta-1, and that is the beta-1 induction of renin release at the kidney, and so that renin release activates the renin-angiotensin-aldosterone system, causing increased blood pressure. All of that increased blood pressure is going to have a reflex. The first reflex is the increase of atrial natriuretic peptide, and the second reflex is to down-regulate antidiuretic hormone. Altogether, with these 2 mechanisms, you get a constant decrease in your body water. It's called catecholamine volume contraction. So as soon as you start giving the alpha inhibitors, you want to also start a high salt, high water diet. You want to get as much volume repletion, restore all the lost volume before the day of surgery, because the second you take that tumor out and there is no longer a secretion of catecholamines in the bloodstream, the blood pressure is going to plummet, and if you don't have the volume restored, you will not be able to restore it rapidly enough with bolus infusion. Intraoperatively, as you're touching and pressing on the tumor, it's going to secrete excessive amounts of catecholamine because it's being agitated, it's being handled, and you want to be able to lower the blood pressure during the operation, and what you're going to use for that is nitroprusside. Nitroprusside, whenever it gets metabolized, it releases NO, and it also releases cyanide. The NO primarily is what it's useful for, to cause vasodilation. I've written here post-operative management. Now let me explain what I mean by that. After you take the tumor out, you're still in operation, but after that tumor comes out, you have a whole new set of risks. It's no longer hypertension, it's hypotension that you have to deal with. So even though it says post-operative, this is at the end of the operation and all the way up through post-operative. And what you do is you replace volume as fast as you can to treat the hypotension. The other thing that the textbooks and everything say that you can use is vasopressin, which is also called antidiuretic hormone. But you give vasopressin, it's going to cause vasoconstriction. Now the next part of this has to understand exactly what you're going to do in the operation. What are you going to take out? If you are doing a unilateral removal, then you're going to take one adrenal gland. You're going to take the whole thing. You don't take the adrenal medulla. You take the entire adrenal gland. In the case where you have bilateral pheochromocytoma, you're going to take both adrenal glands completely. That's going to lose the adrenal cortex's ability to produce cortisol and aldosterone. Even in unilateral removal, you're going to have a loss of total glucocorticoids and mineralocorticoids, and so you need to evaluate, does there need to be a replacement in these steroids? And so you go from there, and that's why I've written here that you can replace corticosteroids and mineralocorticoids. Malignancy and metastases. Okay, so if you can't remove all of it, the primary goal in treatment is to remove the entire tumor surgically. When that's not completely possible, dacarbazine, cyclophosphamide, and vincristine, these are the traditional regimen of chemotherapy. Your other option for chemotherapy is sunitinib, thalidomide, and temozolomide.